Good morning. I'm Michael Fehlings, Professor of Neurosurgery at the University of Toronto, and I'm very pleased to participate in the 6th annual Spine Trauma Summit being hosted by the Seattle Science Foundation. And I have the charge of trying to bring you up to speed with the current state of the art in spinal cord injury. I wish at the outset to acknowledge Jens and Rod for their kind invitation and their friendship over these many years. I work in Toronto. This is my city and the hospital. When the COVID restrictions ease, I would welcome all of you to come visit us. And at the outset, I'd just like to acknowledge the wonderful team that works with me. So spinal cord injury is very heterogeneous, but let's just consider this one case example of a young man, the diving-related C4-5 bilateral facet dislocation and a horrific ASIA complete C4 level injury. So what can we do here for this individual? So I'm going to talk about the concept of time as spine and the concept of early surgical decompression as being a critical intervention. I'll present a reevaluation of the role of corticosteroids, which have been kicked around a lot, but there would be a role, in my view, in this individual with a cervical injury and without significant medical comorbidities. And there are other protective agents which are in the works, and I'm going to particularly focus on riluzole, which is in the midst of a phase 3 randomized trial. I'll then briefly talk about the use of epidural stimulation for chronic spinal cord injury. This is a cool way to potentially bypass injured neural circuits and to stimulate lower motor recovery. And then I'll briefly talk about some bioengineered approaches as well as cellular therapies. So the 3 learning objectives here are to understand this concept of time as spine, and that spinal cord injury is time critical, and surgical intervention is an essential part of the management of most patients. I would advise that the learners learn about the key neuroprotective strategies currently under investigation with a particular focus on riluzole. And the learner should have a basic understanding of the key concepts related to regenerative strategies for spinal cord injury. So when we consider this patient's MRI scan, we can now relate this to an analogous image from a different patient who succumbed from the injury. And one sees a constellation of both the primary mechanical injury of the spinal cord as well as persistent compression and instability. And there's a contusion as well as ongoing compression with hemorrhage in the cord parenchyma. This is a microangiogram of a rodent spinal cord after a clip contusion injury. And the blood vessels have been injected, and we can see outlined the anterior sulcal vessels, which are intact, but centrally, the arbor of blood vessels has been traumatically disrupted, and there's hemorrhage. So this is the primary mechanical trauma, and then around this is this ischemic penumbra zone. And this sets in motion a progressive cascade of axonal and neural damage called the secondary injury. This is precipitated by a number of events subsequent to the ischemia. And then this culminates in the pathology of a chronic human spinal cord injury. This is a post-mortem from an individual who died many years after a spinal cord injury. The hemorrhage has been resorbed. There's a cystic cavitation which is left, surrounded by a glial scar, which serves as a regenerative barrier. And there's been retrograde and anterograde degeneration of the axons. So one of the key concepts to leave you with is this idea of time is spine. And the most convincing level of evidence is based on the Staskus trial. And this was a trial in 313 patients with acute cervical spinal cord injury. And in patients who had surgery within 24 hours, the odds of having a major neurologic recovery of 2 or more ASIA grades was almost 3-fold higher than the control group. And subsequent to this, there have been a number of other studies that have replicated these results, and this has prompted the development of practice guidelines, which were sponsored by a number of groups, in particular AO Spine. And based on these recommendations it is strongly recommended that early surgery be the preferred treatment strategy for patients with any type of a spinal cord injury. Now, what about methylprednisolone? This medication has been used widely in spinal cord injury. It was initially favored, then it came under disfavor, and there's been a lot of uncertainty in terms of where it should be used. And in general, when things are gray, it's often best to leave it in the hands of the physician. This is essentially what I would argue, but I would also indicate that certain types of patients, in particular those with cervical injuries, may be good candidates for this drug as an option. So to undertake this reanalysis, we did an updated meta-analysis with the assistance of Spectrum Research. And this is the forest plot that emerged. And if we look at the bottom portion of the forest plot, we see that there's a statistically significant, though small, beneficial effect of methylprednisolone. So right off the get-go, this type of a difference might not make a big impact in someone with a complete Asia A thoracic injury, but in someone with a cervical injury, this could translate into the recovery of hand and upper extremity function, and this could be quite important. There is no increased risk of death with the 24-hour infusion of methylprednisolone, so I want to put that issue to bed, and in fact, if anything, there is a slightly reduced risk of mortality. And while methylprednisolone does have known complication rates, for example, slightly increasing risks of thromboembolic disease and wound infection, the spinal cord injury is heterogeneous. And it turns out that in cervical spinal cord injury cases, steroids actually have a reduced risk of complications. And this is because the risk stratification is different in cervical injuries. So we used the GRADE approach to issue guidelines for methylprednisolone. Here we took the best available evidence. We looked at the clinical acceptability, having a multidisciplinary group of clinicians involved. We also involved patients and patient advocates to get their perspectives. We assessed benefits versus harms and the costs. And from this, we have the following recommendations. So when started within 8 hours of injury, we suggest that a 24-hour infusion of high-dose methylprednisolone be offered to adult patients with acute spinal cord injury as a treatment option. So it's an option. It's not a guideline. It's not a standard of care. It's an option. We also suggest not offering this treatment if patients present in a delayed fashion after 8 hours of injury. We also do not suggest a longer infusion than 24 hours. And overall, there is no existing evidentiary basis to recommend against the use of methylprednisolone as an option, and I would certainly consider the use in cervical injuries, particularly when associated with early surgical intervention, and especially in younger patients without medical comorbidities. So what else is in the pipeline? And there are a number of neuroprotective strategies, including the use of hypothermia, minocycline, anti-inflammatory drug, as well as GCSF, which is used to mobilize mesenchymal stem cells. But I'm going to talk in particular about riluzole, which is a sodium glutamate antagonist. It's an approved drug for use in ALS, and we've been studying the repurposing of this drug for traumatic spinal cord injury. So this film will illustrate the concepts related to the use of riluzole in our study. We're examining patients with traumatic cervical cord injuries, modeled here as a subaxial burst fracture. The primary mechanical trauma sets in motion a cascade of events referred to as a secondary injury. And here at the microstructural level, we see sodium entering the nerve cells. This triggers cell swelling, and then there's also an entry of calcium. This subsequently triggers a pathological release of the excitatory neurotransmitter glutamate, and this causes excitotoxic cell damage. So these are the classic mechanisms related to traumatic and ischemic neural cell injury. So in the riluzole a trial known as the RISCUS randomized controlled trial, we're studying patients with cervical cord injuries. The patients are undergoing early surgical intervention with decompression reconstruction, as modeled here with a corpectomy and anterior reconstruction. And then riluzole is administered in an effort to attenuate these secondary injury events. We had promising data from a phase 1/2A matched cohort control a trial which was published a few years ago. And in this trial, we found that patients who received riluzole had significantly higher rates of Asia grade conversion, as shown in the left, in the blue bars compared to the red control bars. And on the right, when we plotted out the patterns of motor recovery in cervical patients, we found a significantly improved trajectory of recovery. So based on this, we have launched the RISCUS trial. It's a phase 3 randomized controlled trial. It's the largest trial to date in acute spinal cord injury in almost 3 decades. And 193 patients were enrolled. The trial was put on hold because of the COVID pandemic, with a halt in clinical research. And a planned interim analysis was undertaken. And we just learned that a quote unquote strong signal was seen, with a recommendation to proceed with the trial. And we look forward to carrying this forward. So what else is in the pipeline? The use of epidural electrical stimulation to provoke lower motor movements in patients with spinal cord injury is an attractive option. This is a paper from Harkema and Edgerton's groups showing EMG records from a patient who had a complete spinal cord injury, but where they were able to evoke a movement with stimulation of the lumbar cord. And this was followed by this brief report of 4 patients published in the New England Journal of Medicine. Here's an example of one such patient where significant walking was restored. So this remains to be validated in larger clinical trials, but this is a potentially attractive option, particularly for patients with a severe incomplete spinal cord injury. Now, the lack of central nervous system regeneration has been a big issue. And here I illustrate this again with the glial scar, the cystic cavitation, the degeneration of the nerve fibers. So in vivo therapeutics, this is Bob Langer as a spin-off company, has developed an intriguing neurospinal scaffold composed of PLGA. And this is used to try to bridge the lesion. And in preclinical studies in rodents and in primates, promising results have been achieved. A recent phase 1/2A clinical trial was completed for patients with an Asia A acute thoracic spinal cord injury, which showed encouraging results. And based on this, clearance has been given to proceed to the next phase thoracic spinal cord injury study. Now, what about cellular transplantation? And here in this cartoon, I'm going to show the potential mechanisms by which cell transplants might work. So they might replace lost cells, particularly with neural stem cells. They could provide trophic support, and this is a general mechanism for most types of stem cells where they release growth factors. Certain types of stem cells, in particular mesenchymal stem cells, are thought to immunomodulate and alter the inflammatory environment. And certain types of stem cells may, to a limited degree, also provide scaffold support. And there have been a variety of different types of cellular therapies which have been examined. And I've highlighted Schwann cells and neural stem cells as these have been the 2 types of cellular therapies that have had the most attraction in terms of high quality clinical trials, which admittedly are still at an early level. In this film, I'll show you some of the concepts through which it's thought that neural stem cells may exert their effects. So here we're showing the spinal cord in the microstructure, the axons in the white matter. The myelin sheath is made by the oligodendrocytes, of course, and insulates the axons. The action potentials are fired at the nodes of Ranvier where there are sodium channels, and then there's a precise microstructure to the axon. The myelin is attached to the axons through adhesion molecules, and then there are potassium channels in the juxtaperoneal region. Following an acute spinal cord injury, in general, there's a central hemorrhagic necrosis of the tissues in the center, and there's usually preservation of a thin subpial rim of white matter. Unfortunately, the oligodendrocytes, which make the myelin, are prone to apoptotic cell death, and there's a demyelination that occurs. And then this disturbs the molecular arrangement of ion channels in the axons, and this causes axonal conduction block. Now, what's being examined in early phase clinical trials is a situation where you microinject neural stem cells into the cord, use the patient's own residual white matter tissue as a scaffold, And the neural stem cells are quite efficient at using the white matter niche to pathfind their way around the axons, and they can repair and regenerate the white matter, as shown here schematically. This is some of our own work using human spinal oligodendrogenic neural progenitor cells to promote functional recovery. These are uniquely designed neural stem cells that are biased toward an oligodendroglial lineage, but retain the potential to also make neurons and astrocytes. And we think that this tripotential nature is quite important. The concept here is to actually use the patient's own cells, for example, bone marrow cells, to reprogram these to make these oligodendroglially biased neural stem cells, and then to transplant these back into the patient themselves. And there are very precise protocols that have been developed to derive these human neural stem cells. And one of the cool things in the future is that this could serve as an excellent quality control on before the surgeon actually injects these neural stem cells. And this just shows some snippets of data here. So if we look on the left here, this is a cross-section of the epicenter of a spinal cord in a control animal, huge injury, large cavity. There is some improvement with the regularly fashioned neural stem cells, but those biased toward an oligodendroglial lineage show dramatically enhanced white and gray matter repair and regeneration. And this is associated with substantial recovery at a number of neurological outcome scales. So where are we now with neural stem cells? We're at an inflection point. There have been a number of trials, those funded by Geron, Stem Cell Incorporated, which began with a flourish, but then stopped largely because of financial issues. But in truth, the other issue was that while the cells were safe and showed some promising effects, the effects were very small and insufficient to move forward. So where we're now going forward is that there are a number of efforts underway to use directly reprogrammed neural stem cells. And this is through a spin-off biotech company in Toronto called Intelligex. And the Japanese also have received authorization to test in early phase clinical trials the use of neural stem cells in spinal cord injury. So in closing, the take-home messages are as follows. There are very valid neuroprotective approaches that we can consider right now. Early surgical decompression, the concept of time is spine, I think is a critical take-home message. Steroids have a potential role, particularly in patients with a cervical injury and younger patients without significant medical comorbidities. And there are a number of other protective drugs in the pipeline, but riluzole is showing particular promise with a very exciting, strong signal seen on the interim analysis. And then I've talked about a few other strategies, including the use of epidural stimulation to bypass injured neural circuits and to stimulate lower limb recovery of function, and then various regenerative approaches including bioengineered scaffolds and cellular therapies. And I'm particularly excited about these directly reprogrammed neural stem cells. And on that note, I'd like to close. Thank you again to Jens and Rod for the kind invitation, and I'm pleased to take questions.
Outstanding, Michael. That was a great talk. As usual, that was phenomenal. There's a question from Neil Anand, Michael, asking about steroids and the increased complication rate of pneumonia and some of the pushback from some of the intensivists in the intensive care unit about the use of steroids because of this complication.
Yeah, so the complications that occur in spinal cord injury it's dependent on the level. So what we found in the subgroup analysis from Staskis, and which was replicated by Joe DeTore from Spectrum Research, is that in the patients with cervical injuries, there was actually about a 12% reduction in the complication rates with corticosteroids. And corticosteroids were actually complementary to surgical intervention. And the patients with thoracic injuries are more prone to pneumonia, mainly because there's an often associated chest injury that occurs. So that's maybe one point. So one of the teaching points I think here for us to think about is that spinal cord injury is heterogeneous, and we want to try to personalize the approach. So it's not like it's a one-shot type of a strategy. And we have many skilled clinicians on this call, and we're aware of this, right? So we have to kind of to personalize the approach. So in the patient that I presented, the young man with the diving-related injury, cervical injury, young guy, you're going to get away with the use of steroids, particularly in the first 24 hours. You do not see the systemic immunosuppression until after 24 hours. And this is why there's this narrow time window. Now, in a patient with a thoracic injury, particularly say a thoracic Asia A with a major chest contusion, in that type of patient, I probably would not use corticosteroids, because one is the effects probably won't make a big difference in the thoracic Asia A injury, and there the complication profile might be different in the thoracic SCI. And so one of the points I was trying to make here is like, look, methylprednisolone is not the panacea and the golden drug that it was initially charted to be, but it's also not the death wish, which is also, the reality is in the middle. And the reality is that as physicians and surgeons, you are really in the best place to judge when and where to use these. So young patients, cervical injuries, I think that's the sweet spot.